Hello and welcome. Today we'll be talking about randomized control trial, how to design a randomized control trial, and basically very high level view of how to design the randomized control trial as well as how it helps you coping with the confounders. So next 15-20 minutes, we will go one by one to see how it can help you with your understanding of randomized control trial. To start with, I have no conflict of interest regarding this talk. We will cover in next 15-20 minutes the introduction, where does the randomized control trial or RCT stands, what are the steps to conduct randomized control trials, and selecting your intervention and control groups. There are one or two slides, and then very quickly we will touch upon main points of regarding randomized control trial. So in our previous lectures, you have seen this evidence-based medicine pyramid. The randomized control trial are almost sit on the top, right below the systematic reviews and meta-analysis piece of it. What happens at the time, why they sit on the top is because once you reach to that point, you're no longer looking for association. What you're doing is you're randomizing. Actually, you are controlling the exposure these groups will get it, your exposure group and your control groups. Many of the time the control groups will be getting placebo or the standard care, but you will be controlling those exposures so that you have a control almost of the all parts of the study as well. And systematic reviews and meta-analysis are nothing but aggregation of these randomized control trials or case control studies or cohort studies and put them in aggregates and then talk about it. So that's where they stop. They stay on top higher than randomized control trial. So start with this a quick quiz, and I'll let you read the quiz. Let's say a randomized controlled or blinded trial is properly designed. If it is properly designed and carried out, can provide the most definitive causal inference as a basis for practice guidelines based on evidence-based medicine. And this becomes even more important during current times of this video being recorded during the COVID-19 pandemic. So what's your thoughts around it? Do you think it's true or false? I'll give you a few seconds to think about. So as you would notice that the operative words are highlighted there: randomized blinded trial, definitive causal inference, and evidence-based medicine. So far in our teaching, what we talked about is that if you have prospective or retrospective cohort studies or case control studies or cross-section studies, we stay away from saying that these are causal associations, causal inferences. We just say these are just associations. We don't know it's definitive or not. And sheer design of randomized blinded trial gives us that power to talk about the causal relationship. So that I think the answer you all are coming up with is true. Yes, that is true. It gives us the definitive causal inference if that's done properly and carried out properly. Of course, it can have biases if not done properly. So not only designing part of it, but conducting analysis part has to be robust in randomized control trial as well. Many of you have seen this figure before. And we have talked about the risk factors and disease, the causality piece of it. We talked about the biomarker and disease Y. And so prediction models, we talk about prognosis. Today, we're talking about the last piece in the bottom, which is you're looking for effect of drug or intervention and looking for that effect. And that's an intervention trial. We're looking for your independent cause X and your dependent cause Y you're looking for. And then that's where we're focusing on randomized control trials. Another way of showing it to you that how the randomized control trial, experimental trial stay on the top of it. We've talked about the cohort studies and case control studies, how analytic they are. This is an experimental trial where you are actually introducing an intervention. You're doing a random assignment, looking for independent variable or drug X or intervention X, and looking for a dependent variable outcome Y, and then trying to infer out of it and then make hope in hopes of changing the clinical practice. My apologies for a small figure, but you all know that we have followed this book, Design and Clinical Research. Every resident, fellow, research trainee, medical students who work with us, they go through this book. It's easy to read it. You can finish it in 30 days. In this book, I think this is chapter 10, which talks about what are the steps for randomized control trial. I'll spend a few minutes on just this slide and move on after that. Idea is that there's a whole population. You cannot study a complete population of a city or a country or a city, state, or country even for whole globe. You take a small sample of which is practical for you to take it, and then you look at the predictor measures there. At time, you select the sample, and then where you want to receive the intervention. You measure these predictable variables in terms, and sometimes you put down the baselines as well. In addition to doing intervention, sometimes investigators, they decide to store serum, blood samples, images, and other things for later analysis as well. We call them biospecimen registries within this randomized control trials as well. Now, what happens with these pieces? You have patients put into two arms. One arm, we get the desired intervention. Another arm, they get the control environment as a placebo. Sometimes the placebo is shared as a sugar pill or just a water pill. There's nothing in there. Or sometimes the control arm has a standard of care because you don't want to miss them out. You don't want to deprive them the regular care if even though you're looking for a new treatment or a groundbreaking treatment. In the end, we talk about in one slide where there is a crossover design that both groups get it, but I'll hold those thoughts until the end. Excuse me. So you randomize them. One group is a flip of a coin or computer program, or sometimes the pharmacists know the code and nobody else knows it in that fashion. You flip the coin, a computer gives it, and then consecutive patients start getting either a treatment arm or intervention arm or control arm. It doesn't matter. It's not going to be like one intervention, one control, one intervention, one control. It could be in any random order. That's why the name is randomized control trial. They get these things. Then you follow them over time. You try to minimize the loss to follow up in both groups. Idea is that you want to capture patients or subjects who are good with follow-up and they're not likely to be lost up in follow-up. You assess the compliance with the treatment if it is a long-term treatment as well for both intervention group and control group as well. And then you measure the outcome variable. So think of one thing. If everybody goes through this funnel, one group will be control arm and one will be a case arm. In case arm intervention, you get this medication. Control arm, everything else going to be exactly the same except that intervention or that drug. And you follow these both groups same time with minimum loss of follow-up and good compliance. And then you look at the outcome at the end of these two groups and then say, if there's a definitive answer, you can say that this randomized control trial was helpful in this causal inference. There's no association anymore. If it is helpful, saying this drug is causing this outcome when everything else is being same, if that is true. So that's why these are one of the definitive trials if they are designed well, conducted well, and analyzed well. I would suggest you to go and read the chapter number 10.10, and this figure is taken from this book as well. Now the question comes in, the choices of intervention, the choices of control, what you choose, outcome variables. In our previous lecture, we talked about that outcomes could be single outcome, it could be multiple, or it could be a composite outcome. To give an example, that if you're looking for mortality could be one of the outcomes, or length of stay and mortality, or shorter length of stay and mortality could be an outcome, or ventilator-free days. If there's RCC population, you can say if less ventilator-free days and mortality, it could be a composite outcome. So there could be multiple examples for simple outcome variables or composite outcome variables. And then in the end, I think there are adverse effects. If the drug or intervention is causing some adverse effects, you call them SAE, severe adverse effect. They needed to be reported to Institutional Review Board, Ethical Committee, or FDA if you're designing a medication. There are certain time for it. If these are SAEs, they should be reported within 24 hours of them happening. Sometimes they are not severe adverse event. I think the investigator research team decides that, and they predefine these things when they're designing these clinical trials. And if they're not severe enough or not life-threatening, then you have like certain days, certain time to report to, maybe 48 hours or maybe 1 week. But all severe adverse effect defined pre or unintended should be reported to Institutional Review Board and FDA in real time. I think inclusion exclusion criteria are very important. You want to define inclusion criteria because then you want to have a uniform way of patients coming in for both cases and control. These are defined by the group which is more likely to have the primary outcome. That's one thing that, and I'll give an example about how a teenager female is unlikely or less likely to get cardiovascular diseases. Sample size is derived, sometimes the inclusion criteria that, how much big sample size you want to have it, and that gives you who you need to be included as well. Interaction and stratifications are part of inclusion criteria as well, and I think we'll talk about it in a minute about what does stratification means. Exclusion criteria, anything which is not inclusion is exclusion criteria. So for example, if you're doing a study in adult population, then age less than 18, which is a pediatric population in America at least, becomes your exclusion criteria. As a general rule of thumb, prisoners are excluded in any clinical trial or research unless otherwise it is targeted towards them directly, and you have to have a separate approval process. Majority of trials, if you want to exclude the pregnant and neonatal or fetus in those trials, so sometimes they become just automatic exclusion criteria for your trial. And to go to that length, if your trial includes female patients from childbearing age, then sometimes you have to determine that they're not pregnant. That means you have to do a pregnancy test. Just to give an example, that these are some of the automatic exclusion criteria. Let's go back in more detail about some of the exclusion criteria. And these are 5 points they talk about it. Simple rule is if study treatment is harmful, then you want to exclude these patients. And these examples come from the previous, example comes from previous example we have talked about it. If the trial of raloxifene, estrogen receptor modulator versus placebo to prevent heart disease, that's an example they're taking it here. So if there's a previous DVT or thromboembolic event history is there, then you want to exclude them, and that becomes your exclusion criteria because they are more likely to have certain effects, certain outcomes. And sometimes this is unacceptable. Like people who are estrogen receptor positive breast cancer part should not be given this because that will prompt it. So that becomes your exclusion criteria. The patients who have a breast cancer with estrogen receptor positive, then exclude them. For take this example here on top, if you look for that, if treatment is not likely to be effective, as given example of teenage women who are low risk for coronary artery disease 0, 1, and 2, then because they are less likely to develop the outcome you're looking for, or if they are less likely to develop the disease, then you will not get the desired outcome anyway, so exclude them as well. Type of disease that are likely to respond to treatment, which is valvular heart disease, then not go with the congestive heart failure, the other heart failure, acquired heart disease as well. And the group, you want to exclude the groups, or think about that who are not likely to adapt to the intervention. So poor adherence during the run-in period, this discuss in the next chapter. This one, then you want to identify them and exclude them upfront to save cost and energy. Excuse me. You know that it costs a lot of money in planning to design these trials, and each patient could be very expensive. Each patient enrollment could be very expensive. And sometimes many of these trials pay you by per patient enrollment. So you want to save resources to make sure that you're enrolling patients who are highly motivated and they're likely to stay with the compliance of the study design. Then unlikely to follow up is something important. Sometimes these trials require the patients to come back again after several weeks or several months, and keep coming them for a follow-up or having a phone call. If they're likely to move away from certain states or city, or they're from a different part of the world, then sometimes they get excluded because then you know that they'll be lost to a follow-up, and that might not be a good thing as well. And then patients who have any issues understanding the protocol. So sometimes patients with impaired mental status, patients with Alzheimer's disease or dementia or some of those things, sometimes they get excluded, or they should be excluded from these trials. Exceptions are if the trials are designed to help these patients, that's a different issue. But if you're looking for valvular heart disease, then mental status or dementia, or this could be something, could be your exclusion criteria. So I hope it provides you some clarity that this is just an example. Think about your own study and then apply some of these reasons and see what exclusion criteria, what exclusion criteria you want to build in for your randomized control trial. Excuse me. So this is one of our core principles. We have talked in previous lectures as well. The PICO-RAM. So RAM stands for the patient population. It should be representative of the disease or the group you're trying to look for. It should be attainable. When you're doing your interventions, it should be attainable and outcome as well. Your predictor and exposure variables and outcome measurement has to be measured well. If you have issues on measuring them, then you might not be able to get the desired results, or study methodology will be weak. If I open up PICO part as, which is patient population, intervention exposure group, your control group, and what is the outcome you're looking for. So this is the holy grail of any clinical research you're doing. PICO, that's where you should define your research question. That this is the patient population, this is the intervention group we are looking for, this is the control group, and this is the outcomes. Example is we are looking for incidence. Outcome is lung cancer, and in smokers, that's your intervention group compared to non-smokers in the patient population coming to emergency room or in ICU or anything else as well. So this is your study design, and we have talked about it empty number of times that that's where you should define it. And then when you look for peak or M, is the patient population has to be representative. The intervention control has to be attainable, and they has to be measured well when it comes to outcome and intervention as well. It's a holy grail. If you can remember just one thing from this lecture or basics of clinical research, I think this will be the slide I would like you guys to remember. And again, this comes from the chapter number 9, and I would strongly recommend you to read the chapter 9 to understand this lecture well. Now, very quickly in the last stage of this talk is that there are still the chances and biases in randomized control trial as well. This is same as observational studies as well. But randomized control trial helps out with confoundings in both phases. Once before randomization, which is randomization take care of that piece of it, and second is after randomization when you blind. And then there's single blinded, double blinded, triple blinded studies as well. So how you compare, how you cover for confounding, or how you adjudicate the confounding is you are randomizing patients, so you don't know which patient will get what treatment. And if you blind the teams, patient is blinded, the investigators are blinded, and investigator and treatment people who are giving, they are blinded. And third is that even let me take it back. The patient is blinded, the team who's treating them is blinded, and investigators are blinded. That becomes a triple blinded randomized control trial. If you only blind patient and then primary team, then it's double blinded. Investigators knows what they got it or what did not get it. And sometimes that brings investigator bias. So keep that bias away. What you do is you keep patient blinded, you keep the providers blinded, and third is you keep the investigator blinded. Even the statistician, when they run the studies, they only know group A and group B. They don't know what group they are analyzing it. Once analysis is done, everything is set in stone, then you can take off the label and see which group was which. That is your triple blind, the highest quality of randomized control trial. That takes away any confounding variables from co-interventions or investigator bias as well. And there's a cause and effect part as well that makes sure that cause is coming before effect. And then that's a point number 3 is that this is not possible because you are providing an effect, you are doing an intervention, and you're providing the cause, and then you're looking for the effect later on. So like remember the example of cart before the horse. That will not be possible in a randomized control trial, and that's another beauty of it. And then you have to make sure that your observation studies are also following the same pattern, especially that your cause has to come before effect. Your independent variable has to become before your dependent variable. Your exposure has to come before your outcome, and that is another principle in clinical research. So in one point, the type of randomization is important. And you can have a regular randomization. Anybody gets, you don't know if they can get 3 control groups and then control in one arm, 2:2, 1. It can be any random number as well. Sometimes you do block randomization. That means if there are 4 centers, and by chance they could be that one center will keep getting intervention arm, and one center might keep getting any control arm. What you can do is you can say every time when 4 or 8, block randomization is that, let's say if you're enrolling 50 patients, there are 5 centers. That means each center is enrolling 10 patients. So you can say that out of these 10 patients, at the end of their full enrollment, there'll be 5 controls and cases from each center. It doesn't matter in which fashion comes. That's your block randomization. That means each center is getting equal number of cases and controls. You can stratify blocks as well. You can have a block of 4 that each 4, anytime they enroll 4 patients, there'll be always 2 cases and 2 controls in any random order. That means you're making sure that you can, when you start the trial, there are always an even number of patients in there. And there are some adaptive trials as well, where based on the effect, you can keep modifying your trial as you go along. And that is one of the most famous trials right now. They do adaptive randomized control trials to make sure that you take the best practices in account as you are doing the trial, because sometimes these trials few years. and then new information comes in. So you don't want to be stuck to the old way of doing things. You want to incorporate the newer part doing it. Many of the randomized control trial are being adaptive, looking into COVID-19 pandemic, and see if they can adapt to the best practices and improve upon those, even though these trials are planned few years ago. So you have seen this slide before, just different way of presenting it. But now in this slide, you see this is the experimental study. We have not talked about it so far. So far, we've talked about the left-hand side of part of it. So here you're studying individuals. You are testing a causal hypothesis. You control the assignment. That's a very important part. These are definite trials. If they're done well, they're designed well, done well, analyzed well, then they are definite trials, and the practice, the information comes out from it should change the practice if that is positive or negative, one way that we should not be doing it. I think last slide, this is one of the opportunistic studies as well, which I was talking about, the crossover design, that, you know, you design your study, some people get active treatment, some people get placebo, that's your period one, but you don't want these people to be deprived of the good medications or treatment or therapy. Then you do a washover period and exchange these on the people who got first placebo, now they're getting active treatment. The people who got active treatment, now they get placebo the second now. You can measure things before here, before, after. So if there is a real effect by active treatment, you will see the difference as a delta and before after in both the groups, and you will know that this treatment is working or not. Doing by this way, that at least both the groups are getting treatment. In which arm they are when they get it, that's a different part. First time they get it, first part, this group get the treatment, and second part they go to the placebo arm. Here they get the placebo first time, but they get to the active arm as well. This is a crossover design, which is help to design patients who are in serious illness, cancers, or some of those things, or acute illnesses. So you don't want them to be deprived of some of these opportunities when these trials are being done. So I think that is all for today. Please write your questions in the comment sections and let us know if we can help them. We can help you answer some of these questions, excuse me. And send me an email if you have any questions, and then I'll be happy to talk to you about. Thanks for watching it, and then we will record one more session after this. Thank you so much.